How are you? Good morning, everyone. Thanks so much for jumping on. We did have a short break of lives as Dr. Rusty was overseas on a quick break, but this is our first live back, so welcome back, everyone. We will be resuming our topic of AMH. Before we jump into a new topic as of tomorrow, today we'll just be asking Dr. Rusty some questions that came from user comments, so I'll just dive straight into the questions. The first one being Dr. Rusty. My age is 35, my AMH is 0.6. I'm in a relationship with a male partner. What should I do now?
Okay, so yes, we will be answering some user questions on AMH. So before like Gabby said, before we move to the next topic, maybe later this week we will be discussing my AMH research. So I will go through the research studies we did on AMH. Before that, we'll just answer some user questions. So essentially, what happens with egg reserve? Everyone has a high egg reserve when they're young. Then egg reserve keeps dropping to lower levels. At some stage, it enters critical low AMH level. So you can define it the different ways. So essentially, if you have AMH less than 3 or so, that means you have very low egg reserve. So low AMH or low egg reserve means you have a time limit on your fertility. So that we are not talking about egg quality, we're talking about egg reserve or egg quantity. So then AMH, let us say it goes to critical stage where you have a low AMH less than 3 picomoliters, then goes to the stage where you have undetectable AMH. So undetectable AMH means your AMH is less than 0.6 picomoliters. Why 0.6? Because that's a detection limit of AMH test. So, and when AMH becomes undetectable, then you have got the hidden phase of critically low egg reserve. That phase we cannot tell how long will last in each person. It can really vary. So, and what happens is once you have an undetectable AMH, which means that you may be producing follicles, maybe producing eggs, especially if you're having regular menstrual period, but you're producing AMH from the follicle, but the level of AMH is not high enough in your blood to be detected by AMH test, because sensitivity of AMH test set to 0.6 picomoliters. So so really when you have an undetectable AMH, which is 0.6 or less, first thing you need to do is you need to check antral follicle count. You need to know how many follicles you can see on ultrasound scan on both ovaries. So like we said previously, antral follicle count means you need to measure all follicles which measures less than 1 centimeters on your ovaries. So you do AMH, it is 0.6 or less, then do antral follicle count and establish how many follicles you have. Then after a couple of weeks, you repeat the AMH again and repeat antral follicle count. Why? Because you have a natural variation on AMH and AFC. By repeating AMH twice, antral follicle count twice, you establish your baseline egg reserve. So if you have a low undetectable AMH, high antral follicle count, so that's overall that's good. That means yes, you still have a very low egg reserve or critically low egg reserve, but you have an AMH gene deficiency, which means each antral follicle is producing less amount of AMH than expected. Generally, if you have an AMH of 0.6, antral follicle count should be like 3 or 4 or 5, around that mark. If you have AMH of 0.6 and AFC is like 8, 10 or higher, that means that you actually may have a little bit higher egg reserve than your AMH is showing, and you may have AMH gene deficiency and you're producing less AMH per antral follicles. So then you repeat again, so your AMH may come back a little bit higher, it may become detectable, 1.2, 1.5. In AFC, again, you see the variation. Then you establish your true egg reserve. So, yes, so first you should do AMH, repeat AMH and repeat AFC, so at least twice, then you establish your true egg reserve. So, then if you are in relationship with your male partner, you need to speak with the partner, ensure that you both want to have a child together first, and second is you're both ready to have a child. So if that is the case, if your partner is on board and if you want to have a child together and you're ready to have a child now, then you should start trying to conceive. And of course, while you're trying to conceive, you need to rule out all other causes of infertility. Let us say if you don't rule out all the causes, let us say your partner's sperm parameter is very poor, if your tubes are blocked, then you may just try another 6 months without success, which that 6 months may be very critical for you because you may stop producing eggs. After that, you may go into the phase we call perimenopause. So this is why so you have low AMH, you are in relationship with a male partner, both of you want to have kids and you're ready to have kids now. So then you need to do full fertility workup, which means you need to check your fallopian tubes by doing high COSI. I don't recommend doing HSG. You should do high COSI. So, and the second is your partner needs to do semen analysis. And if you're having regular menstrual period, which means you're releasing eggs. So you need to start trying to conceive immediately. At the same time, as we said, you have a time limit. That time limit may be 6 months or 1 year or longer before you stop producing eggs. So which means during that period, you should start a referral process to fertility specialists. You need to see your GP, depending on which country you live. This process of referral to fertility specialists can be long. It can be like as short as 1 week. Like if you live in Australia, within a week you can see a fertility specialist. If you live in other countries, it may take 3 months or 6 months before you see fertility specialists. So you need to have a parallel track, one track for natural conception by having regular intercourse after checking all fertility parameters. And second parallel track is a referral to fertility specialists, seeing GP, doing all the fertility workups, all the screening tests, and getting ready for fertility treatment, which is usually IVF in this situation. So if you get pregnant while you are doing before you see fertility specialists, naturally that's excellent. The problem is solved. If not, then you need to see fertility specialists and start fertility treatment. In this situation, only treatment adds to your natural chance of natural conception is IVF. IUI doesn't add anything to what you're doing, and ovulation induction you do not need, because in all patients with low AMH having a regular period have a ovulation. You don't even need to check your ovulation by doing progesterone, because low AMH and regular period indicates that you are ovulating. So all other treatments like ovulation induction or IUI doesn't add anything to what you are doing, which is trying to conceive naturally. So next level up to improve your chance will be doing IVF. Why? For example, you have AMH of 0.6, antral follicle of 8. So if you have a good IVF cycle, you should be able to produce 4-5 eggs. And out of 4-5 eggs, depending on your age, egg quality, your partner's sperm quality, you may be able to produce 1 high-grade embryo. So essentially, by doing IVF, you're going 4-5 times faster. Like we said, you have a time limit on your fertility. If you go 4-5 times faster, that may be actual intervention which can help you to get pregnant. So let us say you produce 5 eggs. That's equal to trying to conceive naturally for 5 months. Plus, those 5 produced eggs are inseminated by selected sperm in controlled condition and create embryo and transfer that embryo in controlled condition and support with progesterone. That gives you highest possible chance of successful pregnancy. So depending on accessibility of IVF, like if you're in Australia, if you're not successful, next month you can do another IVF. Next month you can do another IVF. IVF is very accessible in Australia and it's very affordable as well, so compared to other countries. So it depends on your on healthcare setting where you are in, on your overall resources. You can make a plan which tailored to you. I'm just simply talking from point of view of what gives you highest chance of successful pregnancy. IVF may or may not be accessible, but this intervention, repeating AMH and AFC twice, starting referral process to fertility specialists, trying to conceive naturally after speaking to your partner, and if you're not successful within like 3 months or 6 months, then doing IVF is an intervention which gives you highest possible chance of successful pregnancy. That's my recommendation.
Thank you so much, Dr. Rusty. And my second question is, what if you are 32 and your AMH is 2.2 picomole and you're not in a relationship? What would you recommend that patient do?
Okay, so the AMH of 2.2 picomole indicates this person has got very low or critically low egg reserve. So, which means that again, same process, you need to do AFC, and then you need to repeat AMH and AFC once more. So, within maybe 2-3 months here, because this person is not in relationship, she's not trying to conceive now, and her AMH is not that low, 2.2 compared to the previous patient. So, and she can repeat AMH and AFC once more within 2-3 months, then establish her baseline egg reserve. So then she essentially here what 2.2 means, 2-3 years, this person has got functional egg reserve. So which means if she does not achieve successful pregnancy within 2-3 years or preserve her fertility by banking eggs or embryos, then her chance of having a child after that will be extremely low. So still she will be producing eggs quite likely, like we said in previous patient, even AMH is non-detectable, but that period is it's unpredictable. So essentially she really need to focus either on having a child within 2-3 years or need to preserve sufficient amount of eggs or embryos so that she will have a good chance of successful pregnancy after 2-3 years. So here in this situation is after establishing egg reserve, she really needs to either do egg banking, egg freezing. So it's really difficult to freeze sufficient amount of eggs when you have such a low egg reserve. So AMH of 2.2 generally indicates her AFC will be like 6-7 in average, maybe a little bit higher and a little bit lower in some months because of natural variation. So probably if she does egg freezing cycles, she will get maybe 4-5 eggs per cycle in average. So for the age of 32, to get 95% chance of having one child, you need to preserve approximately 30 eggs. So it's not easy to get 30 eggs. So which means if you get 4-5 eggs per cycle, you may need to do about 6 cycles or more of egg freezing cycles. In some countries, egg freezing is very accessible, affordable. You can do 6 cycles of egg freezing across maybe whole 12 months period. In some countries, it's not available or accessible in terms of cost. So it really depends on individual circumstances and healthcare settings of this person. So, but if she does embryo freezing, that gives her higher chance of successful pregnancy, and probably she needs less cycle. Why? Because attrition rate in embryo freezing is lower than egg freezing. And optimization of the cycle in embryo freezing is easier than egg freezing cycles. I'll give you an example. Let us say she's not in a relationship and she definitely wants to have a kids, and she can do if it is an option she can consider, she can do embryo freezing using donor sperm. So in donor sperm embryo freezing, let us say same situation, she produces 4-5 eggs, use fresh eggs with a sperm and create embryo. So let us say out of 4-5 eggs at the age of 32, when you use fresh eggs, very likely she will produce 1 or 2 high grade A or B grade embryos per cycle. So if she does like 4 or 5 cycles, probably she will be able to create like 4, 6, 7 high grade embryos. So that 6, 7 high grade embryo, even 6 high grade embryo gives her cumulative chance of 95% for one child. So let us say she did 3, 4, 5 cycles and got 6 high grade embryos, she can be 95% sure she will have at least one child, or maybe more than one children, because embryos are independent. Each embryo gives 35% chance for her age. So generally embryo freezing is a much better option. So for a number of reasons, probably she will need less cycles than egg freezing. Second, embryo freezing gives better certainty than egg freezing. Why? Because if you freeze eggs, we need to have make 2 levels of assumption before you get pregnancy. First level of assumption is 5 of your eggs will become 1 high grade embryo. That's one assumption. Then each high grade embryo gives you 35% chance, 1 in 3 chance of implantation. Second level of assumption. But when you do embryo freezing, you do one-step assumption before pregnancy happens, which is for each high-grade embryo you created, you have a 1 in 3 chance, 35% chance of successful pregnancy. So you don't need to make an assumption saying, okay, if I froze 30 eggs, I will get 6 embryos. That assumption you don't need to make because it's already embryo has been created, and you just make a one-step assumption, and usually 1 in 3 chance of successful implantation, and you can be fairly certain if you have 6 high-grade embryos at the age of 30, created 32, when you're ready to have a child, maybe after 5 years, maybe after even 10 years, you have approximately 95% chance of successful pregnancy. Neither egg freezing or embryo freezing guarantees success, but if you freeze plenty of eggs, especially plenty of high-grade AB grade embryos, then you can have a high level of certainty that you're going to have a kids. Not 100%, but you can get a 95% chance of having a child. So AMH of 2.2 indicates this person has got time limit on their egg reserve. They have time limit before they run out of egg reserve. The best time for her to either have a child or preserve her fertility by freezing eggs or embryos is within the next 2-3 years. Then it becomes harder and harder and harder. So this is why she has to reprioritize her life priorities, whether it's education, profession, finances, buying accommodation or apartments. I don't know. Everyone has different priorities in this life, but they put a sequence, like my first priority, my career, and second priority, finance, third priority, finding right partner. So there's multiple different priorities. But when you have a low AMH, egg reserve, you need to rearrange your priorities. You may need to focus on fertility first, preserving your eggs or embryos or having a child, then focus on other priorities. So this is why doing egg reserve tests like AMH and AFC gives you very clear fertility timelines, and it helps you to reprioritize, if necessary, your future goals. If your AMH is high, let us say 25 at the age of 32, no, you can just carry on with your current plan and just keep monitoring your egg reserve by doing AMH and AFC tests every 2-3 years, and keep revisiting this question of fertility. But if at the same token, if your AMH is so low, then you may need to reprioritize your life goals and focus on fertility first.
Thank you, Dr. Asti. My final question is, what if a female patient is 26 and their AMH is 68 picomole liters, but they do not have a period? What would you recommend that they do?
So this indicates this person has got PCOS, and because of high AMH levels, high number of antral follicles, this patient is not ovulating. So if she's not trying to conceive, then she doesn't need to worry, because as time passes, naturally her egg reserve drops, her IFC drops, AMH drops, then she starts having ovulation naturally. So if that time, if she's trying to conceive naturally, then provided that she doesn't have any other cause of infertility, very likely she can conceive naturally. So only thing here is to ensure that PCOS is not causing symptoms, stressful symptoms. So she will need to really manage this symptoms of PCOS if PCOS is causing. If she doesn't have any symptoms of PCOS, like high androgen levels and excessive hair growth, so she doesn't really need to worry. At some point, her AMH drops, antral follicle drops, and she will start having regular period.
Thank you, Dr. Asti. That does conclude our live stream this morning. Did you have any further comments before we conclude the live?
Yeah, so we will be discussing, maybe we should discuss my AMH research studies, so it gives additional insight on AMH and antral follicle count. So we did a series of research studies on egg reserve, on AMH, AFC, FSH, and the role of AMH in assisted conception and IVF and overall in infertility management. So, and probably we'll do some live streams on AMH, on my research on AMH, maybe this week and next week. Then we'll wrap up AMH question. And I hope this AMH series, 10 series and plus what we're going to do, will clarify all the confusions related on AMH, so that people will understand the role of AMH and apply on improving their fertility.
Amazing, Dr. Rusty. I'm looking forward to talking through your AMH research. Thank you so much for those that jumped on this morning. As always, the recording of this live will be published on Dr. Rusty's social media channels, and we'll see you tomorrow. Thanks, Dr. Rusty.